My name is Dr. Astha. I'm third year pediatric resident at Mahant Indresh Hospital. And in continuation of the ongoing discussion regarding pediatric COVID management, I'll be talking regarding the oxygen therapy in pediatric COVID-19 infection. And we'll be covering the topics of indication of oxygen therapy, the target of oxygenation, types of oxygenation devices, a bit regarding MDI and pulse oximetry. First, in COVID-19, oxygen is indicated in moderate to severe illness with an SpO2 is less than 94% at room air. Now, the various modes of supplemental oxygen can be divided into low flow system or fixed performance devices. They provide a relatively stable FiO2 level as long as the respiratory rate and pattern are stable. They can deliver high FiO2, but actual amount may vary from breath to breath. These examples include nasal cannula, simple face mask, face tent, non-breather mask. Then our high flow system, they are fixed performance devices. They are indicated in patients with the variable respiratory rate and pattern to provide appropriate FiO2 and to meet a patient's respiratory demand. The examples include Venturi mask, high flow nasal cannula, transtracheal catheter, etc. Now first we'll be discussing regarding the nasal cannula. It's also known as nasal prongs. They are used in stable patient with minimal requirement of oxygen. It is the most common device used for mild hypoxia. They are generally well tolerated as they do not interfere with eating and speaking. They deliver a constant airflow to nasopharynx and aeropharynx and acts as a reservoir of up to 50 ml capacity. At room air there is an FiO2 of about 21%. FiO2 increases approximately 4% with each liter of oxygen. A maximum of 40% of FiO2 and a flow up to 6 liters per minute can be provided by nasal cannula. Now at higher flow rates, the nasal mucosa dries up and there are increased chances of infection. Next is a simple face mask. It's a light face plastic mask. Oxygen inlet is at the base and holes at the sides for exhalation. It is useful when moderate amount of oxygen is needed. They deliver oxygen at flow rates of 5 to 10 liters per minute, providing an FiO2 of 35 to 55%. A minimum of 5 liters per minute flow rate is needed to clear the exhaled gases from the mask. It has to be removed during eating and drinking. Next is partial rebreather face mask. The reservoir capacity increases with the bag. There are no walls between the mask and the reservoir. First, 1/3 of the expiratory gas is exhaled back into the reservoir. The next 2/3 is exhaled out via the side ports. The next breath therefore has higher FiO2. They deliver an FiO2 of 60 to 80% at flow rates of 6 to 10 liters per minute. The collapse of bag can increase the work of breathing. Next are non-rebreather face masks. They are low flow devices with high FiO2. They use a reservoir bag to deliver higher concentration of oxygenation. One-way valve prevents the patient from inhaling the expired air. It can be set between 10 to 15 liters per minute, providing an FiO2 of 80 to 95%. They are useful in severely hypoxic patients who are ventilating well. Next are oxygen hood. It covers only the head of the baby. They are well tolerated in infants. The size of the head limits the use to less than 1 year old babies. It is a fixed performance device and provides an FiO2 of 21 to 100%. A minimum flow rate of more than 5 liters per minute is required to prevent carbon dioxide accumulation. Next are Venturi. Venturi masks are high flow devices. They allow precise measurement of oxygen delivered. They utilize different size of ports to change the amount of FiO2 provided. The Venturi attachments with the reservoir tubing can be attached to a tracheal tube or a supraglottic airway device as a part of TP's breathing system. Next, high flow nasal cannulas. They generate high flow oxygen at 40 to 60 liters per minute. FiO2 of up to 100% can be delivered. They are small pliable nasal prongs. Warming and humidification of the secretion is provided. Continuous positive airway pressure effect is present and they allow patient to eat and speak. However, some patients are not settled by the high flow nasal oxygenation and they may require non-invasive ventilation. A high flow nasal cannula has two parameters need to be set. First is flow rate and other is FiO2. The flow rate is usually set first, and we begin with a lower range of 0.5 to 1 liter per kg per minute, which can be increased up to a maximum of 2 liter per kg per minute. Then FiO2 is set next to achieve a desired target saturation of 90 to 94%. Now we consider providing a 3-ply mask to cover the mouth and nose of the child receiving HFNC to reduce the spread of aerosols. Now flow rate should be maximized if needed in an attempt to keep the FiO2 less than equal to 60%. Now we can switch to conventional low flow nasal cannula system once the flow rate reaches less than equal to 20 liter per minute and FiO2 reaches less than equal to 50%. Now to summarize it, oxygen therapy in COVID-19, we have to give supplement oxygen therapy immediately to patient with SARI and respiratory distress, hypoxemia and shock. A target of more than 94% SpO2 during resuscitation and more than 90% for patient on oxygen therapy and those recovering from pneumonia without any respiratory distresses set. Nasal prongs in cannula are preferred in children as it may be better tolerated. A surgical mask or hood is used to cover the nasal prongs in cannula to decrease the risk of aerosolization and droplet spread. Now, if on prong and SpO2 is less than 90% with minimal respiratory distress, other options include a face mask at flow of more than 5 liter per minute, oxygen hood at flow of more than 5 liter per minute, a venturi mask providing FiO2 of 28 to 60%, and a non-rebreathing mask at flow rate of 10 to 15 liter per minute. A bit about MDI. Now in children with moderate illness who have wheezing or have pre-existing reactive airway disease, we can use salbutamol or ipratropium with MDI with or without spacer. It is preferred over nebulization. We have to avoid nebulization as it has high risk of aerosol generation. Although in intubated children or those who can't use MDI, nebulization can be used with COVID preventive measures. Next, a bit about pulse oximetry. It's based on the principle that oxyhemoglobin absorbs more infrared light than red light, while deoxyhemoglobin absorbs more red light. A light sensor containing the two light sources transmits light through the tissue and is absorbed by hemoglobin and detected by photosensor. The ratio of absorption at the two wavelengths is calculated and calibrated against the direct measurement of arterial oxygen saturation to derive the SpO2 reading. To interpret it simply, SpO2 of more than equal to 94% with no emergency sign requires no active intervention and we can continue monitoring at home. If an SpO2 is less than equal to 94%, the patient requires hospitalization for monitoring and further management. At SpO2 of less than equal to 90%, it's a medical emergency and requires referral to a health facility with an intensive care unit or high dependency unit. To summarize, oxygen is equivalent to a drug and it should be used judiciously. Thank you.